Hello, everyone. Today I will be presenting on CMS Administrator Chiquita Brooks LaSure's discussion on Medicare, Medicaid, and the future of U.S. healthcare system that was held at the Aspen Ideas Festival. This presentation analyzes the key policy problems identified during the event. It evaluates the evidence presented, critiques the effectiveness of the discussion, and reflects the ethical and administrative implications for public services. The focus will be on how federal leadership within CMS addresses issues such as drug pricing, long term care, innovative treatment coverage, and expanding access to underserved populations. To better understand the significance of this discussion, it is important to first examine the context of the event and the specific problems identified by the CMS administrator. This public policy discussion was presented by Chiquita Brooks LaSure, and CMS is one of the most significant federal agencies within the United States healthcare system, providing coverage to approximately 88 million Americans through Medicare, Medicaid, the CHIP program, and marketplace programs. The core program identified in the presentation was unequal access to affordable, high quality healthcare. LaSure emphasized that despite CMS's reach, significant gaps remain in long term care, maternal health outcomes, preventative services, and access to innovate treatments. She highlighted the rising cost of prescription drugs, disparities in maternal mortality, and barriers faced by the underserved rural community in those in the rural communities. The evidence presented focused on the scale of CMS coverage, pressures within Medicare, and the need to modernize reimbursement systems to ensure preventative and initiative care. I found the rationale convincing because it's connected to federal policy tools such as reimbursement structures and drug price negotiations to real systematic barriers affecting those who are vulnerable. The problem was clearly framed as both as a cost issue and an equity issue, which aligns with our current public administration priorities. While the event provided a broad overview of the CMS's role, the central focus of the discussion was the systematic problems affecting access and affordability. I will now go on to examine those issues. LaSure emphasized high prescription drug costs as a structural barrier. She noted that while in the CMS had begun negotiating certain drug prices and meaningful cost reductions require alignment between federal policymakers, state governments, and pharmaceutical manufacturers. Achieving consensus among these stakeholders remain challenging, particularly when innovative therapies carry extremely high price tags. LaSure mentions that low reimbursement rates are associated as a problem and policymakers should consider when evaluating strategies to address Medicaid access gaps. She reported that higher payment levels are associated with measurable improvements in the care utilization among low income populations. Maternal health disparities was also highlighted. These disparities indicate systematic in- inequities access to prenatal and postpartum care, particularly for those, again, in the Medicaid program. By emphasizing the Medicaid finances a significant portion of births in the United States, the presentation framed maternal health was not only as a clinical issue, but also a public policy responsibility requiring federal oversight and targeted reform. In addition, gaps in long term care infrastructures and underinvestment in preventative services continue to strain the healthcare system and increase long term costs. The evidence presented focused on the scale of CMS coverage, cost pressures within Medicaid and Medicare, and ongoing federal efforts to negotiate drug pricing and expand access to innovative treatments. The cost pressures include rising prescription drug expenditures, increasing enrollments as the population ages, and the high price of newly developed specialty and gene therapies. As more beneficiaries require complex chronic care, program spending continues to grow, placing a fiscal strain on both federal and state budgets. Overall, I found the rationale convincing. The problem was framed not only as a financial issue but also as an e- equity issue requiring coordinated policy action. In evaluating the presentation, there were several strengths that stood out to me. The first one was that the policy focus was clear and consistent. Administrator LaSure effectively connected reform efforts directly to federal authorities and CMS administrative capacity. A particular strength was when she deepened into the innovative therapies that were becoming available for Medicaid recipients. She discussed gene therapies for sickle cell disease and other di- diseases, diseases, modifying treatments, highlighting how modern medicine is advancing rapidly. This demonstrated CMS evolving role in covering groundbreaking treatment for historical underserved population. However, she also acknowledged a significant challenge while negotiating with pharmaceutical companies are underway. States often struggle to afford these high-cost therapies. She openly stated that drug ther- that drug costs will likely remain a concern moving forward. I found the transparency to be a strength because it reflected the administrative realism rather than a political oversimplification. The discussion of drug pricing reform and access to new therapies was one of the most compelling elements of this presentation. While the presentation was informative, several elements were also missing that I feel like could have strengthened the policy discussion. First, most state level examples could have been helpful. CMS serves millions of beneficiaries across the country, but identifying maybe the top states where the highest enrollments or greatest reliance of the CMS programs would have added great contextuality to provide a better clarity. Second, although drug pricing negotiations were discussed, more concrete examples showing how much beneficiaries actually save under the CMS coverage would have strengthened the argument. For example, presenting maybe before and after comparisons for specific medications would have made the policy impact more tangible. Additionally, budgetary trade-offs were not fully explored. Expanding access to innovative therapies requires substantial funding, yet their presentation did not deeply address how those costs are balanced against border fiscal constraints. Beyond evaluating the policy substance, policy administration also requires ethical reflection. I will now discuss how the presentation aligns with the ethical principles and faith-based considerations. From an ethical perspective, the discussion strongly aligned with principles in the American Society for Public Administration Code of Ethics. First, expanding access to healthcare reflects the ethical obligation to advance the public interest and promote social equity. Ensuring underserved populations receive coverage demonstrates a commitment to fairness and justice in public service. Second, maternity and morality disparities raise significant moral concerns. Addressing these inequities reflects compassion and responsibility to protect vulnerable communities. Finally, stewardship in managing Medicare and Medicaid funds is essential. Negotiating drug prices and carefully evaluating innovative therapies reflects the duty to manage public resources responsibly while balancing costs um, that affect or provide access to life saving treatments. From a faith informed perspective, these policies align with the values such as human dignity, compassion, and responsibilities and responsible stewardship of shared resources. Building on the ethical framework discussed, it's also important to examine specific policy recommendations proposed to evaluate whether they effectively address the identified problems. Recommendations. The presentation outlined several key policy recommendations. These included continuing drug price negotiations, expanding preventative services, strengthening maternal health access, and implementing innovative coverage reforms within Medicare and Medicaid. The most compelling recommendation was innovative coverage reform. Administrator LaSure emphasized that Medicaid is working to transform how maternal health services are delivered. Rather than limiting coverage to pregnancy alone, reforms aim to extend care before and after childbirth. This includes postpartum coverage, and in some cases, Medicaid will even fund for doulas to support those maternal outcomes. Additionally, CMS is modifying payment modules so that providers and nurses are compensated for spending more time in educating families, particularly those caring for the loved ones with chronic conditions. This reflects a shift away from volume-based care towards a more holistic, patient-centered model. Lasher also described a border approach in which physicians assess social determinations of health, including access to food and stable housing. This holistic strategy recognizes the health outcomes and are influenced by more than your typical clinical treatments. I agree, and these recommendations expanding preventative and maternal care has the potential to reduce long-term costs while improving equity. However, successful implementations will depend on sustainable funding and coordination across all states and the United States. While the policy recommendations are critical, observing this event also provides insight on how various actors influence the policy process. I will now reflect on those roles. So, I think that this go and share assignment helped me clarify the interconnected roles of within the public policy process. First, the role of public servants was evident as a administrator for the CMS mentions that within statutory authority granted by Congress, but also exercises administrative discretion in implementing reforms. Second, elected officials play a crucial role as Congress controls funding and legislative authority for Medicaid and Medicare. Additionally, individual states manage their Medicaid programs within federal guidelines, creating shared governance responsibilities. It is important to note that state and federal governments share programmatic and fiscal responsibility for Medi-Cal. The federal government created Medicaid and imposes programs requirements on states such as covering a minimum of set of services in certain populations. For example, California has typically always chosen to go beyond the minimum federal requirements, such as covering optional services and expanding eligibility to additional populations. Citizens and beneficiaries are central stakeholders as voters and program participants within those needs drive policy priorities. In terms of professional ethics, I observe integrity and transparency in this presentation. The tone was respectful. The discussion was evidence based, and LaSure openly acknowledged that the systems does have limitation and goes through financial constraints. This demonstrated, in my end, honesty, professionalism, responsibility, and an ethical leadership in public administration. In summary, the presentation highlighted a key challenge within the United States healthcare system, including unequal access to care, high prescription share costs, maternal health disparities, and gaps in long-term care. It also emphasized the significant leadership role in CMS administrator managing coverage for approximately 88 million individuals that require, assistance healthcare across federal and state governments that also require complex negotiation with pharmaceutical companies and careful stewardship of public funds. The discussion focused on policy reform efforts such as drug price negotiation, preventative service expansions, maternal care improvements, and innovative coverage reforms. Overall, this presentation reflected federal healthcare priorities at the time of the event. While administrative transitions may alter future implementation strategies, the core challenge of access, affordability, and equity remains central to the public health policy. These themes underscore the ethical responsibility of public administrators to balance costs, contaminant innovated, and a social equity in the serving of public interest. Thank you all for your time.